We'll give it about 2 minutes and then we'll get started. Okay, I'm going to go ahead and get started. Understandably, people will be rolling in, and that's okay. We appreciate all who are able to join us today. Welcome. We know this is a really sad and challenging time for our community, for our nation, and so we're grateful for you to attend this today and really come together for this conversation. And we're grateful for our all-star lineup from University of Minnesota that has a really great program to share, and I think a really important conversation they want to have with you about racism as well. So we're excited for that. Few reminders: use video, please, if you can. Mute if you're not speaking, and remember to unmute. I can guarantee I will forget that, so that's okay. Introduce yourself in the chat if you can, and maybe the organization you're from. And feel free to chat questions and comments throughout. We'll be looking at the chat, and as we can, we'll kind of bring up the questions and incorporate them into the presentation, and then at the end. So, a lot of you have been coming to these webinars, but for those who don't know, I am Jody Dvorkin from ICSI, and my colleague Tani, we're like two peas in a pod. She's with me as well. Tani, do you want to say hi?
Hello, everyone. Really glad that you're here. I'm the director of Minnesota Health Collaborative. Proud to be partnering with Jody in this work. Thank you very much.
So Tani and I will kind of be the facilitators today. Thank you. So before we start, ICSI, myself, and Tani would like to kind of extend our condolences to George Floyd's family, and for all those in our community who are really hurting, which is the entire community. We want to acknowledge that racism isn't just a law enforcement problem. It's a health crisis. It has been for centuries, continues to be so. And so we at ICSI want to acknowledge it and want to understand what we can do to play our role in help stopping this crisis and eliminating racism from healthcare and from affecting health outcomes. So our speakers will get into this way more today, but I just want to share there's a lot of powerful images on social media right now. So it's really hard to pick one because they all kind of resonate and create emotions. But there was one image on Instagram, and I have put the person here, and it was an African-American woman who was breastfeeding. And this is what it said: "I'll feed him, but you have to let him grow." And I think that's what healthcare is about. It's about letting people grow. That's why we all go into healthcare. So that really resonated with me. And, ICSI wants to know how we can be part of the solution. We're talking internally, but we don't have all the answers. So we welcome you to give us your feedback. We're a healthcare collaborative of healthcare systems throughout the state and region and health plans. And we want your input on how, in our role, we can do our part in ending this health crisis. Quick antitrust reminder, ICSI has a strong antitrust policy. If you think that we're veering into something of a competitive nature in terms of pricing, raise your hand in the chat and we'll steer the conversation away. I am so excited to introduce our lineup today from University of Minnesota, and they're going to talk about their Minnesota Resilience Action Plan. We have Dr. Barbara Gold, the Chief Clinical Risk Officer from University of Minnesota Physicians and Professor of the Department of Anesthesiology. Dr. Sophia Vinogradov, Professor and Head of the Department of Psychiatry and Behavioral Sciences. Dr. Jeffrey Wozniak, the professor of behavioral sciences division and the director of that division, and the Department of Psychiatry and Behavioral Sciences, and Dr. Brian McGlinch, assistant professor of the Department of Anesthesiology, and also part of the U.S. Army Reserve and was commander. So really excited for the wealth of experience and information they're about to share. Just a quick food for thought. We always like to do this in the beginning of our webinars as people are still logging in, just to give a couple minutes before we turn it over to really our lead speakers, as we just want to mention something about tensions and polarities. And this is something that my colleague Sarah Horst talks about, and she presented a week ago in her Authentic Leadership presentation, and we wanted to just bring it up here. Really exploring the tension of how can we do one thing and something else simultaneously. So how can you kind of two odds exist at the same time? And I think this is really relevant as we think of mental health support. So particularly what's going on now, how can I support my community and support my workplace and support my home all at the same time? How can I have limited PPE and care for sick patients? How can I work from home and watch my kids? How can I support my team and be worried and scared at the same time? How can I take less revenue or lose my revenue and still meet my expenses? How can I stay current with all the information that's around us with COVID? And how can I disconnect and not always be online? So these tensions, we don't have answers for them, but we think it's important to acknowledge them, to acknowledge what our healthcare workers might be feeling, because we think that's the first step to being able to provide solutions and to intervene. So think about for yourself and your team, what are some of the tensions that might exist in your life and for your organization. And with that, I'm going to turn it over to our speakers. Dr. Vinogradov, I think you're going to kick us off.
I will, and I will let my team members introduce themselves as we come to their sections. Thank you for having us today. It's a privilege to be here. And originally we were going to talk about COVID-19 solely and responding to the mental health needs of responding to, in terms of the response to COVID-19. But today it's really important that we understand that it's been time to shift gears and to honor our feelings that we've all been having this past week and transform our anger and our grief and our fear into systems of support and meaningful action, while keeping in mind that we are all exhausted from the pandemic. I'm going to be sharing with you some slides that came out of a presentation we did yesterday for the medical school here at University of Minnesota, and three of my co-panelists on that presentation, Dr. Christopher Warlick on the left, Dr. Sophia Albert and Katie Lingris on the right, contributed to these slides and to this presentation. Next slide, please. I'd like for us all to take a moment and a moment of silence to really be present with this tragic event that happened. That was the murder of George Floyd, a Black man at the hands of a white police officer. And for those of us who are white, I want us to, during that moment of reflection, I'm going to really challenge you, is to ask, how have I contributed to this situation? And it may be something as what has seemed to be innocuous, such as being in a meeting and looking around the room and seeing that everyone's white, or looking at a leadership group on a web page, perhaps in your organization, and wondering why it's so white. There are many millions of examples we can each come up with, but I'm going to challenge you to think about something where you may not have spoken up or reflected something, or perhaps been as active in a situation as now upon reflection you feel you could have been. So let's just take a moment. Okay, next slide, please. So we're going to take our pulse as a group here today. And actually I'm going to have you go to the next slide because there's something I want to comment on before we come back and take our pulse. I'm a white woman of privilege, and there are all sorts of things that I can do without thinking twice, and that I have done all my life, whether that's going birding or going jogging, or asking for help after being in a car crash, or walking from the corner store, or partying on New Year's Eve. The list goes on and on. These are all activities that I simply do and take for granted. And if you're a person of color, and particularly if you're a Black man, these are not activities you can take for granted. These are activities that may result in your murder. Let's go back to the slide before. So what I want us to do today, just for this will just take a few moments, is check in with ourselves as a group. How were we doing when the pandemic first started? And that was an incredibly painful time, and I want to recognize that. And that's indeed why we formed as a group that we'll be telling you about as the presentation goes on. That's why this Resilience Action Plan was put together. And so how were we doing then? And then let's now fast forward then to today and see how are we doing today, when not only have we now had the pandemic for 3 months, but we've had this tragic death and the unrest that has unfolded from it. So could we show the first poll, please? So here, you're going to need to scroll down a little bit just as you read through these items and just identify for you, what were the top 3 stressors you were experiencing from mid-March to mid-April? It's going to be different for different people. It's going to be different by gender, age, race, and so forth. But we're just going to try and see how we are as a group. So just go ahead and list the top 3 stressors for you in that first month of the pandemic when it was also overwhelming and crazy.
About 60% of people have voted so far, and they're still coming in.
Okay, we can pause it around 70–80%. Go to the next one.
Okay.
Okay. All right, next one.
Let's see. I may need to share the results before I can go to the next one.
Oh, let's look at the results then. Sure, of course.
Thank you.
Let's look at the results. So this is what it was like that first acute month. And you can see it was pretty close between uncertainty about the future and the risk of infection. And by the way, I don't know what results we're going to get. This is, you know, I'm discovering this. And then people, I would say the third one was the social isolation, loss of teamwork. Okay, let's do the next poll.
Okay.
Okay, and now I want you to think back to that same time period when you were having all of those stressors. And now I just want you to identify for you, what were the top 3 reactions that you were having at that time period, first month of COVID? Don't forget to hit submit at the bottom. I just forgot to do that myself.
Okay.
Okay, so let's see where we were with reactions. About 75% of us were fear, anxiety, insomnia. We've seen that in other polls we've done, super common. It looks like about half were feeling the helplessness, hopelessness, frustration, certainly some grief, depression, sorrow, despair. We've certainly saw that. And then pretty good sizable number were feeling that sense of purpose or altruism we feel as healthcare workers and people in the medical field, and healthy coping. Okay, now let's do the same kind of self-inquiry, but looking at where we are today. So could you put up the next poll, please? So same question in terms of your top 3 current stressors, but as of today or the last few days, what's been preoccupying you?
Okay, I'm going to end the poll here.
Okay.
Oh, they're still coming in fast.
Okay.
There we go.
All right. So now we can see that there's been a shift, right, in what we're experiencing as current stressors. We're much less worried as a group about risk of infection. We're much more concerned about uncertainty about the future. You can see that now about half of us are really kind of beginning to think about and understand, for those of us who have not directly experienced the impacts of racism, we are now understanding that racism is a factor that affects all of us, regardless of our skin color. And we see a little bit now in terms of the acute risk of violence as well. And then, of course, social isolation and loss of teamwork continues to be an issue. So let's do our last poll now. And here again, what are the top 3 current reactions, emotions and reactions you're having right now or in the last few days?
We're at 70 and they're still coming in, so I'll wait another couple of seconds here.
So here what we see is, in contrast to that first month of COVID, we're experiencing grief, depression, sorrow, despair. I think that's really worth noting. I think we're seeing that also that increase in the helplessness, hopelessness, inadequacy, frustration. But we're also seeing, and this let's hold on to, because this is what is going to be our fuel for change. We're seeing a really nice proportion of our group feeling a renewed sense of purpose and altruism. This is a call to arms, a call to action, and we're going to respond. So let's move to the next. Thank you all, by the way. This was immensely helpful for me as well. Let's go to the next slide, and then this one. So one question that has come up that Dr. Warlick, my colleague who's African-American, has found people asking him over the last week or so is, why is there such a vehement reaction? And it really is important that we keep in mind that this murder has occurred in the context of chronic and repeated acute traumas that have been suffered by African Americans, and that has happened throughout the United States and also in Minnesota. We also need to keep in mind that here in Minnesota, institutionalized racism has contributed to our state having some of the nation's largest racial disparities in factors such as income, education, and health outcomes, and we need to own that. Many of you already know that COVID-19 has disproportionately affected people of color. And then finally, George Floyd's murder, as I indicated to you before, it's the latest in a long line of murders of Black and other people of color. And it is a particularly egregious murder. All murder is egregious, but this is particularly egregious because it was a murder that occurred under conditions of deliberate cruelty, not something that was sort of a split second, sudden startle reaction. Next slide, please. So what then must we do given this set of circumstances? 3 months of pandemic and now this tragic event and the social unrest. I think it's really important that we make a high priority that we're going to understand the pain and suffering, but also the resilience of others. And that means all others. That will allow us to engender empathy, to build trust, and this is going to foster unity instead of divisiveness. And unity is going to be critical moving forward. But of course, we're psychiatrists and psychologists here with you today, so we feel it's also super important to understand the effects of the current situation. And you saw from your own poll that it has different effects in terms of the stressors and reactions. We need to understand what that is doing to our own mental health and well-being, as well as the mental health of others. And it's this foundation which will allow us to do and sustain the difficult work of change. Next slide. Jeff, I'm going to turn it over to you to talk about the kind of what it was like being under COVID for almost all of us, and then particularly for our fellow citizens who are Black or of color.
Good afternoon, everyone. I'm Jeff Wozniak. I'm a psychologist in the Department of Psychiatry and Behavioral Sciences here at the University of Minnesota. Again, thank you all for being part of this discussion. In the process of working with our faculty and staff and healthcare providers, these are some of the stressors that we've really been identifying. And I would say that the uncertainty it's not an accident that's at the top of this particular graph. It's one of the most salient things that people are feeling. And I think it's been magnified given the situation in the last week about where we are headed, and as a society and as an institution, or as a healthcare institution. So these are the things that we're hearing about and talking to our colleagues, and I'm sure the things that are being experienced in your environments as well. You know, as we saw, the risk of infection is in the background. It was front and center. It's now somewhat moved into the background. We're all still experiencing this profound sense of loss of human contact with other people in this isolation, and we've lost our camaraderie to some extent. We know about the practical barriers that we're up against, financial and PPE and whatnot. Many of us are questioning what our roles are. We're having to step into new roles, having to step into uncharted territory in terms of the types of things that we're doing. Even within our normal healthcare roles. And personally, people are affected by all of this and question aspects of their identity. If we can have the next slide.
I think it's an animation, yeah.
Yeah, there we go. So, you know, all of these experiences and stressors have been magnified in the last week by what has come front and center with Mr. Floyd's death. And this is really brought, for many of us, things that we know are in the background, things that we work to fight against, but the institutional racism that we've talked about, how stereotyping, racial profiling, microaggressions, a pattern of discrimination affects people, how we participate in that. The inequalities that we know are present in our environments, they're divided by neighborhoods, they're divided by color. All of these things have become, you know, starkly clear and front and center in the last week. We live in, as we've been reading about in the Star Tribune, a place where the disparities are great, yet most of us don't see them on a day-to-day basis. Yet these are chronic stressors for other people. And the small feeling of vulnerability and threat that some of us have felt in the last week pales in comparison to what many of our patients and our community members feel on a regular basis. Mental health disparities is also in this chart. So access to mental health care, we know, is disparate, and we continue to work to change, to provide access, but this is an ongoing battle. So next slide, please. You know, these are some of the experiences that people are having. We're feeling anger, we're feeling rage, we're fearful for what's happening around us with the civil unrest. We feel a profound sense of grief and despair for George Floyd, but also for our Black community and our Black colleagues as well. And we feel somewhat helpless and inadequate to make changes. Many of us feel shame because these are things that were kept under the surface for many of us. And we feel cynical about the things that we see in in the news and in our politics and in our community discussions. So these are very, very acute stressors, but they also exist in the background. Next slide. Again, there's a larger context to these, and we need to be realizing that for people of color, for Native communities, for people who are marginalized, all of these things are much, much more chronic and are persistent, and they have an effect on mental health and physical health. Next slide, please. So Dr. Vinogradov has kind of characterized racism as a pathogen in the talk we were doing yesterday. It's really it is really something that it's insidious, and it has the ability to spread and affect us at a societal level. These are some of the statistics. So we know that the COVID deaths and consequences have really been disproportionate for people of color in our community and across the world, really. But yet we also know, as we're talking about violence, that violence is, of course, very disproportionate for people of color, and that this is a public health issue as much as it is a political issue or a legal issue. Next slide, please. This is just to point out that stress has direct effects on the brain. As a developmentalist, I can tell you that we know that stress, chronic stress, affects a child's brain development and leads to permanent changes in the way the brain functions. But acute stress, some of what we're all feeling right now, also affects our ability to think and act clearly. And so one of the things I've been talking with some of our colleagues about is some of the things that happen to your thinking when you're under tremendous stress, which I think all of us are, is we become more binary in our thinking. We tend to be thinking right and wrong, safe and unsafe, productive and unproductive, helpful or unhelpful. We tend to engage in catastrophizing. So when we think about the future, we tend to put a dark color on the future because of overgeneralizing what's happening in the very, very acute situation. We tend to try to predict things when things are not predictable at all. And one of the more dangerous things is that we engage in mind reading, which is a way, and that's in quotes, it's a way of that we fall to assumptions about what other people are thinking. And then we filter their behavior and what they say through that lens. And this is one of the more insidious things that happens and contributes to some of the vehement discussions that people have. As we enter a period where we're hopefully talking more about race, I think it's important to be aware of the fact that our thinking is not as clear when we are under a great deal of stress. So we need to be forgiving of each other as we have difficult conversations. Next slide, please. So these are just some thoughts that we've had about how can we manage stress and move forward together. Individually, we really feel as mental health professionals that it's important to acknowledge all of the feelings that we're having, including the ones that we may be embarrassed by or ashamed of. Feeling angry, feeling resentful, feeling afraid. All of these things do need to be talked about. Fostering your positive emotions as a buffer against that. Spending time in things that are deeply meaningful, whether they're faith-based or spending time in nature. Or talking with people, and then honoring people's stories. Everyone's stories are unique, and that has a place in the discussion. Collectively, we need to be optimistic, and we need to realize that most of us probably on this call right now are in positions to help, and are in positions to help at high levels, institutionally, organizationally, and we should be doing that, working toward collective efficacy. Next slide. Okay, I think we turn it over to Barbara for this next slide. Dr. Gold.
Thank you, Jeff and Sophia for laying this groundwork. And I'd like to pivot now and talk about how we have changed our approach in terms of how we respond to these acute and chronic stressors, and sort of the origins of this, and what we are thinking about going forward. And from the outset, this is certainly an experience we, like you, are learning as we go. And it's been incredibly enlightening and informative. So I'm speaking to this from the perspective of Chief Clinical Risk Officer, and this role is about developing a communication resolution program for adverse medical events. So when there is a horrible medical outcome, how do we respond to it as individuals and as an organization that really honors our patients, that honors our healthcare providers, and attempts to be very transparent and communicate clearly as well as providing some degree of resolution. And one of the pillars of that program was peer support for our healthcare providers as they are going through these very stressful circumstances. And the other pillars were around actively looking at the cases and communicating with the patients, coming to resolution, and also educating others about how we have these difficult conversations when things don't go the way we want them to go, and ultimately result in a terrible cost to the patient. So when COVID happened, we pivoted our peer support to try to deal with COVID, and through some really fortuitous and wonderful circumstances, we teamed up by risk management, University of Minnesota physicians, the Department of Anesthesiology, and Psychiatry. I mean, it's been this wonderful partnership, and who would have ever predicted that? So definitely one of the silver linings of this. And we used a model that was developed by the Army that you'll hear from in a minute from Dr. Brian McGlinch to practically deal with some of these issues. And it tackles all of the elements that Brian and Sophia alluded to earlier. And then, and we put this together in a few days, actually, in 2 weeks, and there's been tremendous need for it. And I would say that this need has been there all along. It's just been silent. And somehow with COVID, we have the permission now to reach out and ask for this type of help. And our premise is, from a risk management perspective, and certainly speaking as an anesthesiologist, as a physician, that if we are not able to take care of our healthcare providers, we will not be able to take good care of our patients. And yes, obliquely, it may be a risk management tool, but really it is a tool so that we can help take care of one another. So when the murder of George Floyd happened and tremendous trauma across our community, it was apparent that many people were suffering and wanted to talk, and that the model that we are speaking of could be adapted to this circumstance as well. So I wanted to give sort of an organizational and institutional perspective. Our goal in developing this is not just to respond to COVID or to the George Floyd murder. It's to develop a cultural shift so that we are comfortable speaking about what is wrong in our culture, our hospital organization, our clinic structure, et cetera, and affect positive change. And we do that by supporting one another and having the expectation that we are checking in with one another and that we have one another's backs. So this is a long road, and one that we are very pleased to be embarking on and learning from all the time. So with that, I would like to turn it over to Commander McGlinch, otherwise known as Dr. Brian McGlinch, anesthesiologist, who will give you more of the specifics around our approach and model. Brian.
Thank you, Barbara. Thank you all for inviting us today. Things in the last 24 hours in the Army have changed drastically. And I think I want everyone to think back of how they first encountered the pandemic, the COVID virus coming into their practices, and the stress that they felt that they may get sick. They may miss a diagnosis and allow others to get sick. Compare that to the soldiers last night from the 82nd Airborne that were flown to Washington, D.C. and forced to put a bayonet on the end of their rifles. That is not what the military is about, but just imagine the stress of that soldier with that weapon and that bayonet facing peaceful protesters in light of the stress that we face going to work. I'm here not in uniform because I'm representing myself as an anesthesiologist that had an idea that was worth pursuing, not as the commander of hospital center in the Army Reserve. So my perspective will come from the experience I have in the military, but I will not be speaking in official Army perspectives this afternoon. So the peer support that you have when you walk into your hospital, knowing that there's a very dangerous disease, and the responsibility of following an order with a bayonet on the end of your weapon are the environments that we both find ourselves in. A very stressful environment, but how do we work through that stress? How do we know that we're going to share this experience and get out of it on the other side in a professional manner? And the Army and the Department of Defense developed this battle buddy program that we're now going to refer to as the buddy system, to de-threaten the terms that we use. This peer support program that the military had, that we introduced it about 15 years ago, there was a rash of suicides that were involving not only soldiers that had been deployed, but also soldiers in the military that had never seen combat. There was something about the environment, the stressful environment that they were in, that required a change. And this peer support group, this peer support program was introduced to make sure that everyone felt important, everyone's contribution was recognized, and that no one would be left behind. This required people to develop relationships with others that weren't necessarily their friends. And that lack of friendship in these relationships was important, because if you're less biased and less fearful of losing a friend, then you are pointing out a behavior or a perspective that's not healthy for the organization. We needed to encourage those behaviors, those relationships. And in order to make those successful, we had to learn to talk to each other. We had to find ways of communicating that were optimistic, that were forward-looking, not complaints or sessions where everything is wrong and we leave it there. We needed to find an environment where it was community that worked together to solve problems. And as the commander of a very large organization, what I need is my soldiers to deal with their conflicts, their issues, their daily stresses at a local level. Because if it gets up to my level, then it's a real crisis. It's a major problem. But most of the problems can be solved if, when you go into work, you have somebody that is your battle buddy that you talk to. You address this problem of, I can't work with Sheila. I hate Sheila. Well, I hate Sheila too. But if you know that you're not the only one with that experience, then you can kind of work around Sheila. You can work around the thing that's always broken, so that you feel supported. You feel as though your contributions and your perspective is respected. And we can address the concerns at work. And that way, when we go home, we can have home as a place for respite, relaxation, so that we can rejuvenate and come in to work the next day and be productive and supportive. So I think the peer support piece is the one thing that I think helps everyone realize that we're all in this together. We may not have had this experience before. None of us have been in an environment where going into work was dangerous. No one in the last week ever thought that driving to work in Minneapolis would be a threat to our own well-being. But now we're all living this chaos. We're living this stress. But do we talk about it? And by being able to find people that we can talk to and say, I'm really stressed out today, or, this thing is really driving me crazy. Knowing that our perspective is important and we can work through these together as a group is a healthy environment. It's a healthy first step in assuring that in the times of trouble, we'll get through this. But most importantly, that we don't throw our hands up and say, you know what, this is just too hard. I'm going to take an easy job. When I think of my role as the commander, I'm really no different than any department chair. If my personnel quit, I have to replace them, and I lose the momentum and the experience and the wisdom that you get with a large group of people that know how to do things right, and they've gone through all the learning. But when we lose our talent and have to rebuild, we are not where we could be. So we want to maintain momentum by having people in an environment that are supportive of each other, allows an empathetic group that we can relate to more easily. Even though I'm not your friend, I know I can talk to you. I know that you'll give me honest feedback, and then we can move together. So that's the peer support piece, the battle system, the buddy system that allows us to have these communities that will work together resolve problems, and then move on. And then in our system, in the MinnRAP program, this is one piece of support that's enhanced by small group sessions. So you got your battle buddy questions that we have people use every day to stimulate conversation. Those conversations are moving along. There's people in our group that think that they may not, I don't need this, but somebody else may need you. I'll close this example with the soldier that's standing there on the Lincoln Memorial with a weapon and a bayonet on it. He or she is looking to the left and right, assuring that the people around us all have the same perspective, that this is really wrong. We've never been asked to do anything like this. We've been politicized, but I know you, you know me, we all are in this experience together. This is very stressful, but these groups will overcome this stress. They'll get back and then work through their emotions of this very highly charged environment, and then be able to do something else. They won't give up and say, I'll never do that again. So that's our peer program. And then I'll step aside and let Jeff Wozniak speak about the small groups that go in to enhance these relationships.
And thank you, Dr. McGlinch. Before I turn it over to Dr. Wozniak, can you talk a little bit about the logistics of how these are set up, what the training is, just for others who might want to replicate it? How does that work?
Well, when we rolled this out at the end of March, we wanted people that were assigned a battle buddy. So it wasn't your friend, but a third party went through and assigned people with respect to their age, their life cycle, their status in their clinical practice. So I'm late middle-aged. I'd have a late middle-aged male with kids about my age, because that's more relatable to me. That's a better peer for me to talk to about the stresses that I have, because I don't have little kids in my house and I'm not dealing with going to work and taking care of, but some of my peers are. So we went on, how old are you? What is your lifestyle? What are your clinical responsibilities? Because if we have a common environment, we have a common language to share between each other.
And Joy, I'm going to step in because I'm one of the time monitors. So I'm just going to watch. And sorry, I don't mean to interrupt you, Brian, but how about we hold on to that thought, because we'll circle back to some of the pragmatics. And then we have a whole website and slew of materials, and are always willing to consult if people want to roll something out similar to this. But again, just in terms of making sure we have time for people to ask additional questions, I'm going to turn it over to you, Jeff, and maybe, again, we can be very brief here. I don't think people need to know details of what the mental health consultants are doing, just touch points.
Right. So Brian described the one-on-one peer support. The materials we send to divisions and units do describe kind of how that should happen and how those should be, the assignment should be made. Level 2 is we assign a mental health consultant to all the groups that we're working with. And that person is just a point person who works with the group, and we recommend that the group size not be too large, but they're regularly available. Let's say it's a department or a division or a particular clinic, to be the mental health consultant and to touch base with them regularly, to check in, to provide advice, and to help potentially if there are referrals that are needed. Let's go to the next slide. I'm just going to mention this very briefly because this could take a long time, but the model that we are using for stress inoculation is exactly what it sounds like. Getting people to think about sort of their maximum stress levels ahead of time and to problem solve around that. So this is a strategy that has been used with other epidemics around the world, and it is found to be useful. So for each individual to anticipate, to write down, to talk about what are the things that are going to really trigger their stress, and how are they going to respond when that happens in a negative way, and then to plan accordingly some strategies for how they will cope with that. Next slide, please. So we talk about the idea of a personal resilience plan. That might mean, thinking about the things that have worked for you in the past, thinking about specific people who are in your support network, who you will go to other strengths that you have, whether they are healthy coping strategies, community related things. What are you going to do when you feel that that stress level has triggered a need for that? Next slide. And then deterring actions involve other people. So this is, again, falling back on the battle buddy or reaching out for mental health support in a more formal way, connecting with the EAP, connecting with counselors. It's a broader effort to engage people in deterring the stresses that are happening. We thought about this as an idea of herd immunity, that the more people that we can have within a group doing this, the better off the group is going to be. And once people start talking about these things, the dominoes kind of fall, and everyone feels like they can engage in something that they were hesitant to engage in previously. Next slide.
Right. I want to be able to kind of end on a note of some specific action items that we can all be doing right now as part of both taking care of ourselves, our colleagues, our fellow citizens, and our community. These are some first steps about taking these very intense emotions we've all been experiencing into meaningful action, meaningful change. Obviously, always start with self-care, whatever works best for you. Do be cognizant that self-care may change for different individuals or different communities. Connect with your colleagues, all of them, but particularly check on your colleagues of color, your African-American colleagues. This is an incredibly difficult, unspeakably difficult time for them. And don't ask them to fix your emotional response. Don't go, that's not their job. Your job is to let them know you're thinking of them, ask how you can help. If you're a supervisor, check in with your teams and your supervisees and see if time off is needed. And I think that, again, that's particularly germane for African-American, Black, people of color, members of your team. And that is because given kind of, again, the way our institutions work and operate and the particular scrutiny they feel, they may be very worried that it's a sign of weakness or it's a sign of, I'm going to be judged. In my department, it's time off, no judgment. In fact, I've been actually reaching out to various specific people and saying, I want you to take time off. Call on colleagues to help cover. I mean, within yourselves, again, if you're maybe supporting someone to take time off, make sure other colleagues are stepping in to help cover as needed. Absolutely practice self-compassion. We are all stumbling here, trying to sort the right thing to do. We will make mistakes. We will say wrong things. We will wish we had responded differently. Practice active self-compassion. Be kind to yourself. Take breaks. We are all in this together. Our colleague Katie Lingris uses the choir analogy. At any point as a choir is singing, not everyone is, some people are catching their breath, right? Not everyone is actively engaged in the singing. Make sure that you take your time out of this collective endeavor to get your breaks. And then, of course, extend compassion to each other. I think Brian so strikingly pointed out that it's important that we experience compassion for these young soldiers who are being asked to do this really unconscionable action, that we extend compassion to police officers around the country who are fine and in our own communities who are incredibly humanitarian human beings who've been placed into this really horrendous situation. So compassion is going to be key. Next page, next slide. And then finally, next steps, and I think this is about addressing the pathogen that is racism. It makes not only individuals sick in terms of their physical and mental well-being, it makes a society sick. We are experiencing the sickness now. Our society is on a ventilator. Here are some ways you every day can start taking next steps that are going to start addressing this pathogen. Speak up. Silence is betrayal. That can be in response to seeing or hearing biased comments, actions, portrayals, policies. Can also be starting to pay attention in your own institution. Who's not at the table? Who's not part of our leadership team? Who's not part of our hiring pool? Listen to each other. Here at the University of Minnesota, we're fortunate that we have faculty and staff and learners who've long been advocating for changes in how we operate. They've been writing about it, they've been teaching about it. It's fascinating that there's been this chronic institutional resistance to taking this work super seriously or to integrating it in a meaningful way in everyday practice. What is that resistance to change? We all are responsible for self-inquiry there, and to start really taking advantage of this body of work and knowledge. To do this, we're all going to have to get comfortable with the uncomfortable. Those of us who are white are got to get ready to really go into some deep dives around self-inquiry. We have to go to the edge of our comfort zones and beyond. We have to talk to children about what's happening. And again, as I mentioned before, please don't ask your colleagues and fellow citizens who are Black or Indigenous or people of color to do more emotional work. They are not there to hold our experience or to make us feel okay. So really consider when you are talking about how inconvenienced you are because a certain store is closed or a certain street is closed, keep in mind that some people come from communities where that has been an everyday occurrence throughout their lives. Next slide. We're talking about a very dark situation right now, dark on so many levels. It's important to be optimistic. Being able to take a really clear-sighted view of a very dark situation already is itself an act of optimism. And I hope that today has presented you with some aspects, some pieces of that clear-sighted view. And then finally, optimism is itself, justifies its own existence. Our ability to know that things can get better and our ability to hold the expectation that they should, that's our fuel. That's the thing that's going to create the change that is going to allow us to progress. Next slide. We will share with you, we have a very deep and rich learning and resource list, and we can share this with you as a group. I would say in terms of not getting overwhelmed, you can just dip into any of these and see a number of anti-racism resources for those of you in the audience today who are white. Start just with just one. There's readings, there's videos to watch and so on. Just try one. Try it today. All right, thank you. We can open it up for questions or discussion.
Fantastic. Well, thank you. Thank you for kind of both those presentations, really shifting to address kind of the current situation and really tackle the discussion of racism. Appreciate that. And then talking about your kind of peer support and emotional support system, which is really helpful for racism, COVID, and Dr. Gold, as you said, really a cultural shift in how can health providers help one another. So Tanya, I don't have access to the chat. Can I have you read off any questions, and please chat them in or feel free to speak up.
And I can take a minute to briefly address the pragmatics of the rollout. And it's very simple, which is you need to have a champion within a given unit or department or division who thinks this is important and wants to sort of help own it or hold it. And that champion, either alone or with a mental health consultant, meets with the leadership of a given unit, department, et cetera, and says, we're proposing the buddy system. We're going to recommend that people within your unit or division create buddies based on similar demographic and role features as Brian described. And that buddies check in with each other, and they check in with each other regularly. If things are calm, once a week. If things are acute, 3 times a day. Sharing responses, validating each other, checking in with each other, giving honest feedback. I also believe that this system could be a real force for change if buddies started to challenge each other on racism, if, for example, if they happen to be white, or if 2 buddies happen to, or if a pair of buddies happens to include somebody, an African American, that person can start challenging and bringing up ideas for real action. So I could see that this can be a force not just for supporting one another around the kind of each other's individual mental health, but really challenging each other to be taking action and maintaining action over time. If you have the availability of a mental health consultant, that mental health consultant can jump in and provide additional ideas, forums, small groups, whatever you happen to need. This week, Jeff and I and others on our team have been very busy just offering those kinds of small group or larger group presentations. But that's not necessary. You can, anybody can have, but it can have a culture where there's that the expectation is that you have a buddy and that you're checking in with that buddy.
So, Sophia, can I just add one more thing, that this model is very, very flexible. So certainly in the Army, there are 18-year-old recruits who come from, as Brian has educated us, from all sorts of different backgrounds where this has been useful, as well as to folks who are in high roles such as Brian's at the commander level. So, and we have adopted it to many different units, departments, divisions, sites within our organization. So very customizable and very flexible.
Thank you so much. Any questions?
We did have one come in from Jessica Malone. Jessica, are you able to unmute and ask the question?
Sure, Tani, absolutely. This is Jessica, head of in healthcare. Joellen Kozlowski, one of our psychology managers, has done a ton of groundwork to talk to you guys at the U about the Battle Buddies program, and has laid the groundwork for us in various departments to kind of take that and launch the program in our departments. I'm primarily working with our inpatient psychiatry department to get people interested. Although I know there have been similar struggles on one of our med-surg units that was kind of on the forefront of caring for COVID-19 patients, and they've had similar struggles. Although I've got 3 staff champions, a nurse, a mental health worker, and a therapeutic recreationist, we were having a lot of trouble getting staff to say, hey, I want to be a part of this. I either want support from a buddy or want to be a buddy. We've been communicating extensively, and I went around with treats with flyers about the Battle Buddies yesterday. So we're trying all sorts of things, but wondering if you've run into similar things and how you've been able to get around that and get people involved.
Mm-hmm. Jeff, you're probably closest to that.
I would say a couple things. One, it may help to just assign people. It may seem a little bit awkward, but sometimes people need to be, they need to be signed up for their 401k automatic because they're not going to do it on their own. So in this case, they may just need to be assigned. And then once you start to build momentum, more and more people start doing it. We've come to the conclusion that the mental health consultants should have somewhat of a regular presence, but not a lengthy presence at department meetings and division meetings and things like that, unless it's called for. But to have a steady presence and a reminder, periodic reminder that this program is in place and that we are talking about mental health and we are talking about now race, more shorter exposures is probably better than an intensive type of exposure. So those are 2 thoughts that I had.
I would say additionally, what we've learned is you have to meet people where they are. And if there's resistance for a reason. Or if people this is not meeting what their needs are, we have to respect that. But we believe what we're trying to do is just inject this idea that it's okay to have conversations, believe it or not. In a lot of healthcare systems, that's not okay. Doctors don't do that and stuff. And that it's okay to have, and even know that, like a mental health consultant is a colleague. It's another form of peer support, just happens to be someone in the Department of Psychiatry. And hey, it's Jeff. It's not this mysterious thing out there, right? It's Jeff, who every now and then is at a faculty meeting or every now and then sends out an email. So again, we can just sort of, normalize some of this. Whether or not people are making active use of it. I would say the second piece is that what we found, particularly and extremely unfortunately this past week, is because we already had kind of an infrastructure in place that when needs became acute within groups, we knew how to quickly mobilize and respond. So even by last Thursday and Friday, some of our mental health consultants were able to kind of set up what people wanted that week, which was some small group drop-in sessions. It didn't take us a week or 2 to scramble and find people and get them to have a relationship with a given unit or department. They already had that. They could reach out. They could say, all right, let's do something Thursday or Friday. And they were able to do that.
So thank you. I want to be mindful of time. Absolutely. If you have more questions, send them along to us. Tani will have a follow-up email and we'll pass it along to this kind of dream team here, and we'll get you your answers back, because we want this really to be a network. That has been the goal of these webinars, is that you all can learn from each other, replicate the things that are working. So we want to help facilitate that as much as possible. Quick announcement, just please go to our website. Our next webinar will be in 2 weeks. And our mental health playbook, a kind of a guide for systems to kind of support their healthcare workers, are in there with kind of some of the promising practices that have been shared. So again, just thank you so much to our presenters. Really appreciate you doing this really kind of insightful, emotional, and very much needed presentation today. So thank you for your time. And thank you to everybody who had the time to join. Stay safe, be well, and we will talk to you in 2 weeks. Thank you, everybody.
Thank you, everyone. Take care.